he will give you a call. Now, please, we are live. Then you can say.
We are live, sir.
Good morning, everyone, and welcome to day 2 of this panel discussion on opportunities in medtech. Today we have 3 very interesting sessions, and we are going to start with the oncology session. And we have 3 eminent luminaries who have done sterling work in this field. And I have the pleasure of welcoming them and introducing them to all of you. Let me start with our moderator, Dr. T.S. Ravikumar, who is currently the president of AIMS Mangalagiri. And he is also the member Board of Health Technology Assessment in India and the member of the WHO Global Patient Safety Curriculum Working Group and advisor for the Heart and Stroke Foundation of India, which is a subsidiary of the American Heart Association. So Dr. T.S. Ravikumar came to India from the US after over 36 years of service in various capacities with the main aim of looking at service in public sector for the underserved rather, and system design for quality and patient safety, testing models for universal healthcare. And he was appointed as the first director and CEO of JIPMA Puducherry after it was designated as an institute of national importance. He completed his MS in surgery from Madras Medical College in India, and later on completed the American Board of Surgery in addition to FRCS from Canada and Edinburgh. He is a fellow of the American College of Surgeons. So his appointments in the US include a long and illustrious list. He was assistant professor and later the associate professor of surgery at the Harvard Medical School. He was associate professor and chief of the surgical oncology, Yale University School of Medicine, professor of surgery and molecular biology, Robert Wood Johnson Medical School, and chief of surgery at the Cancer Institute of New Jersey, and was later the surgeon-in-chief and senior vice president for surgical services at the Montefiore Medical Center in North Shore Health System. He held the university chair and John D. Mountain Endowed Professor of Surgery at Albert Einstein College of Medicine before he came to India to take over as the director of JIPMA. He is internationally recognized for his work in colorectal cancer and liver surgery and patient safety. He has authored over 230 publications in peer-reviewed journals, abstracts, and has also published several book chapters. He is a recipient of numerous awards and honors, including the top doctors listings consistently since 1995. He is a member of several surgical and oncological societies, including the Society of University Surgeons and the American Surgical Association, just to name a few. He is the past president of New York Surgical Society. New York Daily News had actually named him as the 21 New Yorkers to watch for in the 21st century in his 2000 Millennium Edition. So under his under his leadership, JIPMA was, for the first time in its history, received the Award of Excellence as Best Hospital with Medical School Non-Metro for the year 2014-15. And there were several other accolades that JIPMA had won under his sterling leadership. He had initiated several projects at JIPMA, including a 400-bed women and children hospital as well as an academic center, a large student hostel complex, and specialty block expansion. And a Center for Advanced Research is established with the idea to see far in conducting longitudinal research, which was also part of his initiatives. And later on, he joined the Sri Venkateswara Institute of Medical Sciences, where he established 10 institutes of excellence. And for the first time, SWIMS is ranked among the top 100 medical institutions in NIR of 2018 ranking, both in the overall and university categories, and also in 2019 among the top 30 medical institutions. His leadership has led to the initiation of several population health strategies, such as community CPR and Pink Bus for women's bundle cancer screening. We are really happy to have him amidst us. He will be moderating today's sessions, and we look forward to his very useful and valuable inputs. I will also have the pleasure to introduce the 2 speakers for the day. First, we have Dr. Arvind Krishnamurthy, who is a professor and head of surgical oncology at the Cancer Institute, Adyar, Chennai. He did a super specialty oncology training from the prestigious Tara Memorial Center in Mumbai. His areas of clinical interest are thoracic, head and neck, and breast oncology. He has authored 175 publications, which also include 6 book chapters in peer-reviewed international and national journals. In addition, he is an avid anti-tobacco crusader. In recognition for his matchless dedication to the practice of medicine as a human service vocation, and with a track record of non-commercial services to the poor and needy, without compromising on professional excellence, he was awarded the Dr. K.S. Sanjeevi Award in 2011. He has several awards to his credit, as well as including the Best Doctors Award from the Tamil Nadu Dr. MGR Medical University in 2012 and the Ian Valluvar Award in 2010, as well as the Sushrita Award in Medicine 2019. Welcome, sir. We look forward to a very insightful session from you today. Our next speaker for the day is Dr. Bishwajit Dubashi, who is currently an additional professor at JIPMER, Pondicherry. He is an MBBS MD in internal medicine from JIPMER and also a doctorate in medicine in specializing in medical oncology from the Adyar Cancer Institute in Chennai. He also has received ECMO, which is a European Certified Medical Oncology certification. He has 12 years of experience in this field of oncology and 15 years of experience as a medical professional. And he has over 70 publications in the field of oncology in various peer-reviewed international and national journals. His areas of interest include clinical hemato-oncology, which includes transplant, breast, gastric, and thoracic oncology. And he is also carrying out active research in the fields of pharmacogenomics, biomarkers, and drug trials. He has received several awards, which includes the IACA Travel Fellowship for Bone Marrow Transplant at Wisconsin, USA, and the International CML Preceptorship for Advanced Training in CML at Adelaide in Australia. He is a member of the European Association of Cancer Research, European Society of Medical Oncology, and a life member of the Indian Cooperative Oncology Network, ICON, and the Indian Cancer Society. He also is a member of the American Society of Hematology. So I welcome all of you to this panel discussion, and I look forward to a very informative and interactive sessions, which I'm sure is going to trigger the youngsters who have registered for this course, and also faculty to embark on research in fields that are identified by you as pain points for the oncology sector. Over to you, sir, Dr. Ravi Kumar.
Very good morning to all of you who are participating. And thank you, Dr. Uma, for the glorious introduction. Some of it is probably true. And also Dr. Swami and Dr. Anuradha for enabling me to participate in this august panel this morning. And I also have distinct pleasure of welcoming my co-panelist, Dr. Arvind Krishnamurthy, whom I know through the surgical oncology fraternity. And of course, my favorite oncologist, Dr. Biswajit, who has put oncology JIPMER on the map. And also he propelled the bone marrow transplant unit. And I have very passionate love for him. And I'm looking forward to hearing him as well, both of them. But from my perspective, I just want to put one issue to frame, which is be very relevant as this ableist, this fantastic program that Sastra is going to bring in, will be useful to create a milieu or the environment to nurture the future leaders of the oncology. When I was at Harvard, I will take only 2 minutes. I gravitated to Harvard Medical School and Dana-Farber because I was given an NIH award for a fellowship, and I wanted to choose the best possible. At that time, I was interested in cancer immunotherapy using colorectal cancer as a model. And the Dana-Farber Cancer Institute at Harvard had as its president, Baruch Ben-Asaraf, who got the Nobel Prize for T suppressor cells, the whole T cell lineage. So I thought, what better place? And I went to beg him to take me in his lab. Of course, he had a better scientist to mentor, but of course, he told me to participate in his lab meetings. And I was chosen by the surgical oncology group at the Brigham and Dana-Farber. And my lab was set up along with a senior mentor at the room 1712, 17th floor, which I passionately remember. And having been in that early environment, gave me lots of ideas. And not only that, to apply for grants, partly successful, mostly unsuccessful, from Global and NIH. And I did understand a lot on immunotherapy, immunology, working in that environment. Now, fast forward, I became a young faculty member at now called Bethesda Deaconess Hospital. At that time, it was called New England Deaconess, part of the Harvard system, next to Dana-Farber and the Brigham. I was recruited as a young faculty member, one of the first faculty recruits after the new chairman came in. And my lab was continuing in the room 1712 at Dana-Farber. Then came one person by name William Kalin. He was a young fellow, 2 years behind me, and we used to work together. I was a young faculty doing all the consultations in Dana-Farber for surgical oncology. And Bill Kalin worked under David Livingston. David Livingston lab was on the same floor and then many other floors. David Livingston was working on tumor suppressor genes. And under him, Bill Kalin joined. And Bill Kalin was working on a very esoteric disease called von Hippel-Lindau disease, von Hippel-Lindau syndrome, that causes renal cell cancer. I was also interested in tumor hypoxia, and Bill Kalin was interested in tumor hypoxia. And my interest was very superficial. That's where what I am today. I'm not in the higher level. And I was interested in destroying the tumors in the microenvironment using ablative technologies, and causes tumor necrosis by collapsing the microvascular architecture, and also to shrink the tumors using cryosurgery, later on radiofrequency ablation to heat the tumors. I was interested in what is called a HIF, hypoxia-inducible factor. I tried to work a little bit on this. Bill was also working on this. And thereafter, our paths diverged. Come 2019, I hear Bill Kalin, whom I knew as a young faculty and a fellow who joined, got the Nobel Prize in physiology and medicine. His work has continued longitudinally, looking at a tumor hypoxia, looking how the oxygen sensing mechanism in the cells work. That took him from one to another, and he got the Nobel Prize along with, shared with two others in the world, Radcliffe and others. And he got the Nobel Prize of how cells sense oxygen. So that is what I want to bring in, to create a nurturing a milieu where people can take the ideas forward longitudinally, work with the global best, and become an environment. So you can create it like a tumor microenvironment. I want this group to create a microenvironment for nurturing the talent and young blood. And so that will be the goal that we have to set 10 years from now. Maybe we'll produce somebody at the same caliber as Bill Kalin, not the caliber as Ravi Kumar. Thank you very much for this introduction. And with that, as a opening remark and the opening batsman, I want now the two heavy hitters to take it on after me. Thank you.
Can I share my screen?
Dr. Arvind, yeah.
Shall I call Arvind Krishnamurthy to take on Dr.
Good morning, everybody. At the outset, I'd like to thank the Sastra University leadership, Dr. Swaminathan, Dr. Anuradha, Dr. Uma Maheshwari, for having me here. Just trying to make this full screen. Yeah, and that was a very inspiring bit of information from Dr. Ravi Kumar, you can hardly make out that he's a surgical oncologist. In fact, as a surgical oncologist, we normally talk more of surgery, but then the thing is that in oncology, we are taught to be multidisciplinary, and that's exactly what the flavor Dr. Ravi Kumar gave us. And my also regards to Biswajit, who was with us at the Cancer Institute some time back and is now doing great work at the JIPMER Puducherry. I bring greetings from three wonderful institutions that shaped me: the Madras Medical College, where I did my MS in General Surgery, the Tata Memorial, 2001. I joined there, 2001. 2004, I finished my MCH and then came to the Cancer Institute at AR. A comprehensive cancer center, 4 pillars of work it does: the hospital or the clinical service as a comprehensive cancer center, academic training, and this is what constitutes about 80% of my work. Clinical research, little bit I do, much less than what Dr. Ravi Kumar has done and achieved, and a little bit into preventive oncology services. I'm also one of the consultants for the task force of the NCD wing for the government of Tamil Nadu. I'll just try to walk you across a journey of a surgeon and try to sort of see where is the scope for technology to fit in as an enabler. In general, the patient management, there are 3 broad systems in which cancer treatments are given to the patient: surgery, radiation therapy, and systemic therapy, or the medical oncology part that Biswa would be covering. As a surgeon, I would try to give some perspectives of surgery and where technology has sort of revolutionized the management, little glimpses about reconstruction, rehabilitation, and a lot of focus on cancer prevention and early diagnosis. Of course, palliative care is there, but I will not have time to touch upon it. Prior to the act of surgery, it's very important that this patient goes through a process of pre-surgical optimization. And this is really very important. It's not just that the patient comes today and we take him to the OR table the very next day. Prior to surgery, a lot many things happen. And this is, I feel, very, very important. We'll have to involve the patient. A lot of patient education and informed consenting process is very, very important. As clinicians, we try to physically and mentally, socially, we try to optimize the patient's the general health, the cardiovascular health, habits, nutrition, distress, rehabilitativeness. All these things have to be sort of taught to these patients. And I feel virtual reality is a platform that can help the clinicians, especially oncologists, in optimizing the patients. Virtual reality, of course, it's come a big part to age now. Initially developed purely for entertainment purposes. Now, of course, you have it all in handsets and wristbands, and a lot of scope in optimizing these patients. A lot of 3D models are there for virtual recording and virtual reality. And a small survey of a couple of patients, of a handful of patients, were shown a complex vascular surgery or as a model. And this was published in a couple of years back in the Annals of Vascular Surgery. And almost all these patients seems to have enjoyed their experience, and they felt that they were much more involved and interested in their own health. So virtual reality programs can make the patients more inclusive and make them more involved. And this is especially important where we are in an age of, we are largely being a very litigant society. Documentation and informed consenting is becoming the norm of the day. Audiovisual consulting is there for clinical trials, and I'm sure that in due process, audiovisual consulting may become the norm for regular surgeries as well. So VR has a scope of better informing the patients, keeping them interested, and making it as a part of the consent. So this is an important scope, which is not much talked about, but I thought I should sort of highlight this. Also, a very important factor is the amount of stress that happens. And the stress is not just for the patient, the stress is also there for the medical staff, considering that we are becoming an increasingly litigant society. Whether you're waiting to have an operation done or whether you're actually performing it, there will be some amount of stress. And there are a couple of publications, and there are a couple of brands are available, like the Biha VR or the V Relax, that's available in the market, that gives a user-centered program, not just for the patients, but also for the surgeons. So this is another scope in which technology can contribute in reducing the stress, not just for the patients, but also for the clinicians. Now come to fast forward to the actual performance of the surgery. And surgery has evolved over the years in 1980s and 90s. And to a large extent, even now we do a lot of open surgery, but from 1990s onwards, there was a shift to minimally invasive surgeries. When I was training, the norm was the bigger the surgeon, the bigger the incision. In fact, I used to remember in Madras Medical College, every time the professor used to come to the operation theater, the first thing that you would do after scrubbing up for a patient was to slightly increase the size of the incisions. Like, for example, if they're doing something in the abdomen, right from the xiphisternum to the pubic symphysis, increase the incision. So they say that, you get much more visualization, but that's not the norm today. I think the surgeon is now defined by the size of the incision. Smaller the incision, the better it is considered for the surgeon. A lot of scope for minimally invasive surgeries. We are doing more and more of the minimally invasive surgeries, especially the laparoscopic surgeries. Very recently, we stepped into the robotic platform, and tomorrow there would be a lot of scope for micro robotics as well. And the advances, and I just thought that I would give you all a flavor of what's happening. We are increasingly moving to smaller and smaller incisions. Initially it was 10 mm, 8 mm, now it's 5, 3 and allows 1 ml, and now it is a single incision robotic surgery. Either you could have a spider robot, or in which there is a one small incision, or the docking would happen outside the patient, which is called as an air docking. And the other scope is to do what is called as a NOTES, or natural orifice surgery. For example, the thyroid gland can be removed by means of using your scope through the translabial approach. So these are certain advances or innovations that are happening in this group of surgeries. We also have a lot of other surgeries called the awake surgeries or the tubeless surgeries, especially in thoracic surgeries. And the goals of all these minimally invasive surgeries is definitely proven to have better short-term outcomes for the patients. Less pain, less hospital stay, quicker recoveries, early return to work, great economics, better quality of life. And there are some provocative data to say some of these minimally invasive surgeries also give long-term better oncological outcomes for these patients. Of course, robotics in surgery is not a new concept. We have close to about 100 robots in the entire country. But the major problem with the robotic platform is the costs. And even now, in a place like us, it is becoming increasingly challenging to sort of run the robotic program. And so the need of the hour to have a cost-effective solution for a robotic program. We need more innovations in the robot, safer robots, better navigation robots. And I think in the future, the robots will have to travel to the patients rather than the patients travel to the operations. The future of the OR is also another important concept that I thought to sort of highlight. I think we would be moving more and more into a smart or a hybrid operation theater. That means the operation theaters are not just equipped with standard operative equipments like the OT tables, lights, etc., but it would also be equipped with advanced medical imaging devices like the C-arms, CT scans, and MRI scans. Somewhere also you could have a number of screens wherein you can relay to anywhere in the world. There is also another scope. The surgeons need not actually see a monitor while operating. You could actually have your own set of Google glasses, and this is some technology that is already there, but there is scope for innovation. So rather than seeing the monitor, try to see the Google glasses and get the same image through the glasses rather than looking at the monitor. Lot of advances and lot of scope for advances can happen in intraoperative navigation, and this is something called as an image projection hologram. So if you're operating, and like in the cartoon that I've shown, the image guidance or the navigation system tells us what is behind this structure, what are the blind spots. So if supposing there is a large blood vessel which is there, then the system sorts of tells you that there is a blood vessel there. Hey, you sort of relax and operate carefully. So augmented reality image overlay guided surgery is possibly going to be the future of surgery. And localizing devices are also becoming very, very common. Nowadays, we have lesions which are, like, say, very, very small, a few millimeters. For example, because of CT screenings for lung cancer, some of the lesions are less than a centimeter. Sometimes it is very, very difficult to see these lesions with the naked eye. So there is a scope for advances in localization of these by placement of fiducial markers or radio frequency guided chips, which are being in use, and a lot of scope for betterment of this can happen. Also very important in terms of storage and recording of the data, and there is a scope for dynamic recording. So sometimes what happens is in the OR, when we want to record certain things, there is sometimes a difficulty. So we use what is called as a GoPro system, which is head mounted in the heads of the surgeon to record exactly what your eyes are seeing. So now the future will be in the terms of smart contact lenses. So the contact lens, which is which the surgeon or the operating surgeon would wear. At the blink of it, it would sort of capture the data. This smart contact lenses could actually be linked to Bluetooth, and which will have an enabled hard disk of about 1 TB or 8 TB. So at the blink of the eye, you can start recording, and all the information from what the surgeon is actually seeing will be captured by the smart contact lens, and it can be transmitted to the hard disk wherein storage can happen. Surgical automation is something which is there. Possibly, it started off because a robot was actually asked to suture an intestine of the pig, and initially it was used with the use of guided markers. But now they've seen that the robot can actually perform the surgical tasks on their own without the need for a marker. And they believe that fully automated robotic surgery, right now in the robotic surgery, what happens is the surgeon sits far away from the patient in the console, and the surgeon actually controls. So it's like a master and slave, where the surgeon is the master and the slave is the robotic instruments, and the movements of the surgeon are amplified on the body of the patient.
He has network issues. We'll just wait for 2 minutes for him to join back.
Dr. Swami, it is not, are we still connected?
Yeah, we are connected. But,
we are connected, but I think this network connection got lost. So he would reconnect.
Yeah.
In 2 minutes, he should be back.
Yeah, I think, sorry.
Yeah, hello, sir.
I think you all lost me.
Yeah.
I'm sorry. I'm really sorry about that. Like, I know sometimes it just happens because when you're in your workplace, I'm extremely sorry. I apologize for this. I think this is where I think you guys can sort of chip in and make it much more better for us, essentially. 1 second. Yeah. Yeah, is it seen now?
Yes, Dr. Arvind, we lost you when you were talking about totally automated robotic surgery. That's what we lost.
I'm sorry. So yeah, exactly. So the future would be for the automation to work alongside with surgeons rather than replacing surgeons. And this is what I mean. Like, for example, it's akin to a car driver who drives an automatic vehicle. Supposing the wheels are always on the hand of the robot or the car, should anything go wrong, then the car driver takes over. So similarly, I foresee that this robotic surgeon would play a role. So it will not be that it will be fully automated, at least in the foreseeable future, but this will be sometimes from what I see in the near future. The remote surgeries can also happen. For example, a surgeon in the US can operate somewhere another surgery which is performed at any other country. Right now, the signal lag seems to be too great, but with the evolution of 5G networking and technology, and I believe in certain countries in the world, this has been possible. It's very useful in war surgeries, wherein the surgeon can be stationed at a remote place and then he can operate. And this is something that that is something that can be done. The other main aspect is about rehabilitation, and I would sort of go into 3D printing technology, and this has really replaced and transformed how surgery and rehabilitation is done in the planning of the surgery and the effectiveness of the implants. Basically, what happens is that the CT images, or whatever the images are there, it is transferred to a system, and then the implants are designed for the patients. It has really disrupted in the way the surgical workflows happen in terms of tailoring the preoperative consultations. As I said, you can show the 3D models to your patients, better educate the patients, better make them better ready. Surgeons can actually do surgical training technique rehearsals also of these patients, and you can also have some bespoke solutions for instrumentation and implants. And the advantages of 3D printing are that surgery can become more safer, precise. You also have avenues where surgery was once considered very complex. Now, because of the advent of 3D printing rehabilitation, those surgeries can be done very much safely. The other aspect is regarding surgical training for surgeons. And this is where, again, virtual reality has played a big role, rendering. I remember when I was training, we had to sort of, lay on some sort of cadavers only to learn our anatomy. And I believe cadaver dissection is still useful at this point of time. But I feel surgical training will be revolutionized by the use of 3D models for anatomy and physiological training. And there are a lot of things available in the market, like fundamental VR, health scholars, tech solutions, etc. And this is one area where I feel a lot of scope for improvement can be there, and also with regards to the robotic training technology. The other important aspect that I saw not often talked about, less talked about, is scar formation for surgeries. When we do certain surgeries for patients, some patients heal well, some patients heal very poorly. Sometimes fetuses heal without a scar, whereas young adults sometimes heal with scar. It's just not only a cosmetic problem. There is no clear-cut solution as to who heals better, who heals bad. And a potential solution was given by a couple of scientists from the Stanford by nailing a gene called ghrelin. And this gene can be targeted by means of a drug. And they found that in certain experiments, when some of part of the wound healing was related to the mechanical stress, by blocking the mechanical stress by means of particular drug, what they found was the normal healing could happen. And this is something which I thought was revolutionary, because it has an application not just in oncology but beyond oncology itself. It's believed like 45% of the Americans, and we have data from America to say, they die because of fibrosing or because of scarring. And this phenomenon of scarring can occur in very many organs of the body, in liver fibrosis, burns, abdominal adhesion, scleroma, or many other rheumatic conditions. So I feel that if we sort of disrupt or interrupt the process of scarring that happens, then we can make a big difference in the outcomes of not just oncological scars, which is more than cosmetic, but also in a host range beyond oncological services. But I think the majority or the big impact will be in terms of the use in prevention and early diagnosis. Artificial intelligence, I think it has disrupted radiology and pathology. I'm sure you would have had discussions with a lot of radiologists and pathologists as well. In terms of breast cancer screening, mammograms read by artificial intelligence, it's really happening quite a lot. And this is I believe that this will disrupt the field of artificial intelligence in breast cancer screening. In case of lung cancers, we are working with Johnson & Johnson and AstraZeneca to see whether some chest X-rays can predict lung cancers, because 90% of the lung cancers that we see are locally advanced or metastatic cancers. So we are seeing by a way in which artificial intelligence can read the chest X-ray, because chest X-ray is a normal thing that we all do for various purposes, and especially in the COVID era, not just X-rays, but CT scans are being abused. But I'm sure what is happening is, as a fallout, we have been diagnosing more amount of lung cancers because of the over usage or abuse rather of X-rays and CT scans. But I must say that we can use these technologies of artificial intelligence to study the X-rays and CT scans to pick up early the lung cancer, so that we can diagnose them at a much earlier stage. Other oral cancers, again, there is a lot of scope for imaging and spectroscopy for artificial diagnosis of these cancers. Of course, there are lots of apps that I feel will be there in the area of cancer screening. iBrush you can have for oral health, and maybe oral cancer screening. iToilet, depending upon the sort of how you're able to the direction of your stream of your micturition, it can sort of predict some prostatic health or prostatic problems. Stool, goax staining or fetal occult staining. There is a thing called iToilet in which you can sort of so there is a scope for colorectal cancer screening by this. HPV self-testing in cervical cancer screenings, but it would become just like a pregnancy test. Like, right now, pregnancy test, woman just puts a drop of urine, she knows. And I believe a lot of cancers may get diagnosed, and HPV self-testing for cervical cancer is one such potential area where technology can be used for screening and early detection of these cancers. And we are going to have an era of genomic driven prevention as well. Prevention, prediction, analysis, and early diagnosis will all be genomic driven. We as surgeons would be forced to perform certain risk reducing surgeries. For example, if a lady is diagnosed to have BRCA mutations, it's not just in breast cancer, but the relevance is coming in many other cancers like ovarian cancers, prostate cancers, pancreatic cancers, etc. So we may be landing up doing much more of the risk reduction surgeries for these patients. But the potential pitfall is a lot of patients may be overtreated. For example, because of the Angelina Jolie effect, a lot of women with solitary breast cancers also opted for double mastectomy and bilateral oophorectomy, thinking or perceiving that their risk would be much higher than what is there. So these are the pitfalls, and this is something that one must consciously think. So it was very important for us, the oncology communities, to estimate, contextualize, and communicate the risk adequately to the patients prior to using the genomic data for performing the risk reduction surgeries. So the future of technology, everybody will think that it would have a great impact on the workforce. The workforce will be eradicated, but I don't think it is there, at least in the field of medicine. Clinical relationships with the patients will continue to be paramount importance. And I believe compassion, empathy, and human touch cannot be simulated, and it cannot be given back. So my final thoughts: the best way to predict the future is to create it. And I believe by collaborating with institutes like Sastra, and in fact, the IIT Madras incidentally is our neighbor, I feel we can collaborate with them much more than what we are doing at this point of time, is to collaborate to create a cost-effective solution for the vast majority of Indians. I believe that with the technology, we should arrive at a solution that's cost-effective so that the majority of us use it. If it is not used by the majority, I think it's not a solution. So and with these thoughts, I would like to end my speech, and I would like to thank the Sastra University leadership for the opportunity. I'm open to the questions, and once again, apologize for my audio-visual glitch. Thank you.
Thank you. Thank you, Dr. Arvind, for your comprehensive, erudite presentation. In the interest of time, we will go to Dr. Biswajit and revert back to questions if we have time. Otherwise, he will be not be able to give his presentation. So, with the permission of the organizers, can we ask Dr. Dubashi, the Biswajit Dubashi, to come on now?
Yes, sir.
Good morning. Are my slides visible?
Yes, sir.
Good morning. At the outset, I would like to thank Professor Ravi Kumar. He has been my mentor, and when I joined JIPMER as a faculty and started the Department of Medical Oncology there, sir was there, and he guided me throughout his time period when he was in JIPMER. He is not only a brilliant academician, but also a brilliant administrator, and I salute Ravi Kumar for whatever he has done for JIPMER. The next, I would like to also thank Shastra University, Dr. Anuradha, Dr. Swaminathan, Dr. Uma Maheshwari for giving this opportunity. This has been a different kind of challenge while I was preparing the slides, because this is something which a medical oncologist does not do. He gets up in the morning, he goes, takes the chemotherapy drugs, administers, manages the adverse events. So when such a topic was given, it was thrilling to go through some of those areas. The disclaimer is I am not an expert in this area, but some of those thoughts which I think we can take forward, and these are the areas where technology can definitely help in improving oncology care. So what I did is I've divided them into three groups: diagnostic, therapeutic, and research. And I feel that top 8, some of those technologies which will definitely change in the next decade would be: 1, artificial intelligence, which also will include some of the technologies like chatbots, and then early detection by genetic screening, and then you would look at tele-oncology, then smart devices for cancer, and therapeutics. We would look at nanotechnology, which has already been there for the last 2 decades, which is becoming more and more relevant, stronger in the area of oncology, and also the newer part, which is the immunotherapy and the CAR T cells, which has really changed treatment outcomes in some of the malignancies which used to have dismal results. I think Dr. Arvind Krishnamurthy beautifully summarized in his presentation on the surgical part, and at the end of his presentation, he was looking at something called artificial intelligence. And there's a lot of things going on with artificial intelligence. The buzzing word is machine learning, and people are feeding data from millions of data into the computer and developing machine learning algorithms. And these algorithms are helping us not only developing screening modules, developing therapeutic modules to also help patients get treatment better. And I believe that artificial intelligence in future would help in one already we discussed in screening. And there's a lot of work going on, as Dr. Arvind Krishnamurthy said, on lung cancer screening, as well as for breast cancer. And basically you put in a lot of images into the computer, and the computer gives out some kind of algorithm. And when you feed in a kind of, you feed in a patient's X-ray or a scan, then it tells you what are the possible outcomes in these patients. It is very, very important in our country, where we do not have manpower during screening, where we do not have technicians to report. This comes in very handy, where you just feed in the image and you get outputs from there. One of the areas where we would be very interested as a medical oncologist would be looking at an infection pattern on imaging, especially in leukemias. When we treat, we get a lot of this fungal infections, and we are not sure what kind of fungal infections or a bacterial infection. And you could look at a particular pattern, image pattern, and we would be able to pick up this, and it would help in early pickup of these infections. Other areas would be digital pathology. We know that with the pathology is the grammar of oncology. Without a proper diagnosis, you can't actually treat patients. And if you actually are able to get this pathology digitalized and remote access to the slides, then it becomes very easy for somebody, especially in a COVID situation where people cannot go for work and reduce the work stress area. You could actually sit at home and look at the slides and report them. So AI-based digital pathology would really be very useful when we are having so many immunohistochemistry markers, too many slides for patients, and we need to report them. The other area could be radiation delivery. We know that radiation delivery is very, very important, because you also need to, when you deliver radiation to the tumor, there is some scatter radiation to the normal tissue, and you would like to reduce as much as possible, reduce the scatter radiation to the normal tissue. And this also, the AI could help in identifying which could be a normal tissue area and which could be a cancer area. Then there's a lot of things happening on personalized cancer treatment. You look at reducing the time for doing clinical trials. I will just show in the next few slides, where actually a clinical trial takes 10 to 15 years for it to mature. And if you could have AI and we have some kind of artificial algorithms, we could actually reduce the number of patients on which we need to do this test, and probably approve drugs sooner. Then the buzz has been the immunotherapy in the last 5 to 10 years, when we know if you actually strengthen your immune system, you could attack the cancer cells, and you could actually cure some of these cancers. And the one challenge to immunotherapy has always been that it's only some 20% of these patients who actually respond to immunotherapy. So immunotherapy is quite expensive. You give to 100 patients, actual benefit is only for 20 patients. And identifying this 20 patients has been always difficult. The current algorithms do not allow us, and probably an artificial intelligence, when more and more immunotherapy patients get treatment and you are able to get an algorithm done and predict success to this, would be very nice. Other interesting one, when I was going through the internet, was looking at a surgical knife, which could be an intelligent surgical knife, what they said. So if you actually, when you're doing surgery, it's very important to get a margin negative thing on when doing a surgery. So sometimes there could be a microscopic tumor left behind. And if we could develop some kind of surgical knife, when you place the knife over that part of the tissue and that it says that yes, tumor is there, you excise, so then you could excise. So something interesting on the AIs. This is one of the examples of how AIs can be used for reporting pathology slides. And then the drug development phase, which can be completely reduced by doing in silico models and developing artificial networks to actually give to challenge these drugs in very few patients, but onto the virtual patients, which could reduce the time of clinical trials and get approvals yearly. So the other interesting part would be the chatbots. This has become quite common in the time of COVID. You go to a Swiggy and you try talking to a customer care, and then the customer care, there is no customer care. So there is hardly any customer care now, and everything is converted into a chatbots. And the chatbots could be very useful for follow-up of our patients. When you, let's say, a patient is given chemotherapy and you are having some side effects, and then a doctor or a nurse is not available, you could actually discuss with the chatbot, and the chatbot could actually give you some solutions to some of your side effects. So this would be a very interesting thing which could actually change, which could help physicians help treat patients better. The other one is obviously it's already there, the text recognition speech, especially in a busy OPD when we need to type in lots of things onto our MRD records. It's very, very difficult. And if you are able to get, it's already available in US, but most of those are to a particular slang, and our Indian this thing is it does not accept. So these are some of these things which could be developed for our country. Tele-oncology, already Dr. Arvind had discussed lots of it. It's not only just a tele-consultation. You could be doing telepathology, you could be doing tele-radiology, and there's lots of virtual help of tele-oncology, a 3D version of, Dr. Arvind beautifully summarized how tele-oncology will help us. Some of the diagnostic areas which we could look at are some of those radiopharmaceutical, already a PET scan, which is already so much into the market. Last 10 years, we are able to identify metastasis better, tumors better, but there could be still better methods of molecular imaging probes where you could actually start picking up mutations on radiopharmaceutical and see whether this particular mutations are there in all the sites of tumor, or it's only on a particular site of tumor, because tumor is so heterogeneous. Sometimes we believe that a particular mutation may be there in one part of the tumor and may not be there in other parts, and this molecular imaging probes might be very, very useful. PET CT scan is already there in the technology. PET MRI is coming up. PET MRI, the fusion technology is much better than a PET CT in some of those areas. There are some places where you could just use some particular cell stain to detect cancer, especially for screening purposes, where you do not alter the morphology. Just before sending for your pathologist, you could just put in and look at which site cancer is there or not. The other interesting part would be point of care tests, like the biomarker chips for early detection. So this would be very interesting. You just put a drop of blood in a biomarker chip and you would know some of those screening malignancies which you have or not. Liquid biopsy has already been there in the market for some time, but it's not, there are very few takers, few malignancies which have adopted liquid biopsy for diagnostic. Other imaging technologies like angiogenesis, hypoxia-induced, apoptosis, endocrine-based imaging techniques are also something which can come up. Other personal interest is, my interest is in gastric cancer, and we know that it's very difficult to pick up peritoneal disease from the current whatever investigations we have. And there is no imaging modality which actually picks up a peritoneal disease, and something which we could develop for detecting peritoneal diseases better. Therapeutics is the area. One of this is like something like an automated chemotherapy preparation unit. You have, this is something which I thought would, you have a computer where you just put in the vial. The computer is fed in with all the volumes, and then it just measures the correct amount of chemotherapy, does all the preparation, and you just get an output. It prevents exposure of all the health workers to chemotherapy systems. There are interesting drug delivery systems. Already we know nanotechnology is already there. The nanotechnology is becoming better and better over the years. There are other interesting drug delivery systems like the dynamic BH3 profiling. Some of the vesicles, extracellular vesicles have been used. DNA cages have been used where you actually put in the drug inside a DNA cage, and that can be opened only by the cancer cells. People have been working on this. Immunotherapy is one area where things have actually dramatically changed. And one of them is the CAR T cells, where you engineer your T cells to become better T cells and attack the tumors better. The CAR T cells cost somewhere around 2.5 to 3 crores currently in US for treatment. So in India, it's still a dream, but hopefully in 10 years time, when already people are working, IIT Mumbai is currently working on CAR T cells, and probably it should be available at affordable rates in the country. Equipments, we know some of those intraperitoneal chemotherapies you do. There are some equipments like hyperthermic, pressurized intraperitoneal chemotherapy, extracorporeal photopheresis, which is there in the market, very expensive, something which we could develop at a much lower cost. The alopecia has been a long drawn concept. People have tried all methods, but there's no actual really an equipment which is available to prevent alopecia. These are some of the areas where definitely research can be tried. This is one of the dynamic BH3 profiling units which people are looking at. You just put a cell onto the cancer cell onto the plates and do a specific BH3 peptide exposure, and then you would be able to predict the response to a treatment for a particular patient, very personalized to a particular patient. This is what I told about a DNA cage. You put the drug inside a DNA cage. When this DNA cage goes only near the tumor cells, the cage opens up and the drug is absorbed by the tumor and the tumor dies. So actually there is no toxicity to the normal cells. A few slides on immunotherapy. I think everybody must have read about CAR T cells. She was a young girl, 9 years, when she developed acute lymphoblastic leukemia. She had relapsed. We know a relapsed acute lymphoblastic leukemia, the survival is almost dismal. So at that point of time, they did not have any much clinical trials. And Dr. Karl was working on this something called the CAR T cells, where they engineered the T cells to attack the cancer cells better. And when he had applied to NIH, they actually did not, and NCI, they did not actually give funding. They said that this is just a waste project, it does not work. So a lymphoma society gave him some money, and actually the first CAR T cells was given to this girl, and the tumor completely disappeared, and she's living now and of the disease. So a very interesting area where the CAR T cells are basically the engineered T cells. You actually engineer the T cells, put it into a viral vector, and inject back into the patient, and then the tumors are just killed by the enhanced activity of the T cell. This is from IIT Bombay. They have been working on this for the last 2-3 years on the CAR T cells. And in fact, yesterday there was a publication in Molecular Cancer Therapeutics where they have actually designed the first CAR T cell, which has a beautiful, robust anti-tumor activity with a very low cytokine production, and will go into a human trial very, very soon. So this is areas where the other area is research. And I think there are lots of sequences are already available, but you would like to have high throughput sequences, more accurate, more reproducible sequences. Most of these sequences are currently for whole exome sequence, whole genome sequence, very reliable. But again, the sequences are not very great for methylation studies, for transcriptome sequencing, and requires a lot of refinement. And imagine if you are able to also integrate machine learning algorithm to detect the variants, then actually you could get a report immediately. Anybody who has done a whole genome sequence or a whole exome sequence knows how difficult it is to actually pick up a variant. It takes days, 4 or 5 days, and it's a very rigorous process. You require a bioinformatics to help you out. If you could actually put in an artificial algorithm, then you could actually get reports quite soon. Then people are looking at single cell isolation. People are looking at a holographic life image microscope. Some of them are looking at spectral overlap technology, where actually you could use multiple fluorescent antibodies at one time. So if you have one cell, currently if you add 2 or 3, beyond 3 or 4, the machine, the equipment is not able to pick up the fluorescence, and you could actually, these are some of these things which are coming up. And there are also probes to measure exogenous volatile compounds, which currently the gas chromatography does, but you could look at an easy, today there was a news in a paper where you could actually do a breath test and detect COVID immediately within few seconds. So again, my take-home message would be definitely very challenging area, a lot of innovation, especially for youngsters working on these areas. These are some of those areas where you could actually focus, and I think things would be great. So at the end, I would like to thank again for giving this opportunity. It was a very good revision of areas, and over back to Professor Ravi Kumar to conclude. Yes, thank you, sir.
Thank you very much, Dr. Biswajit and Dr. Arvind. Before we open up for some discussion, I have only 2 points to make in my role as the moderator. What has COVID pandemic taught us in catalyzing the rapid advances in oncology? I just want to mention 2 things. One is how this revolution in vaccine production from concept stage to real world experience has come in 15 months from the beginning of the genome being identified. Of course, it's a single RNA, single strand RNA, it's easier with 30 kilobase pair and all, that's different. But the whole process I'm looking at, learning from this pandemic experience, in fact, I'm proposing it to across all the aims. There are new aims, including like JIPMER. There are institutes of national importance now, about 20 of them, 15 new aims and existing 5 of them, to have clinical trial collaborative group. And oncology could be a good paradigm. I would like to enlist both of the panelists today to support me on this. So where we don't need to go to the old paradigm, even when what I learned in US in the clinical trials cooperative group, learn from the COVID pandemic, how we can accelerate from discovery in the current context, in Indian context, how we can build a very robust clinical trial platform. And this could be one thing for the ableist also to catalyze this kind of sastra to catalyze. So that could be one learning point for me, where we can not wait for 10 years and 15 years and make only 5% of the clinical discoveries come into real world expression, and make that into accordion plate without cutting any corners. This vaccine production and deployment and development and the real world experiences taught us, let us learn from this, and next 2 or 3 years will really revolutionize the cancer platform. That's one learning message. The second thing is tele-oncology. What has given us in terms of telemedicine? The COVID pandemic has made it an obligatory how we manage our daily activities. Even my own aims in Mangalagiri, we have this platform. I call that hub to hut, but the e-Parmesh, we call that Parmash. So we do that in terms of tele-oncology, not tele-oncology, telemedicine concept. So tele-oncology is ripe for this innovation, as both of you have very nicely outlined. These are my take-home messages from the COVID pandemic, how we can learn from this, the abysmal thing we are going through, and to see the silver lining, how we can take it to oncology. That is my remark. Thank you very much. And I'm going to be listening to the questions fielded by Dr. Uma and others to the 2 panelists. Thanks, both of you, for the wonderful comprehensive review.
Thank you, sir. Thank you, all of you. It was really a wonderful session and has given us so many new leads as to work on. There have been several questions, so I'm just going to quickly post them. The first one goes to Dr. Arvind. When we opt for surgical oncology, my question is, how many sequencing studies are done per 1,000 population? How are we going to consider the non-druggable mutations?
Well, that hardly ever, no, we do sequencing, but I understand that in the future, what is going to happen is sequencing would be a part of the staging and diagnosis of the patient. So right now, what happens is, prior to getting started off with the treatment for any cancer patient, what we do is we take some tissue, and that's, I think, pretty obvious. We take some tissue, we study it under the microscope. The pathologist sort of, gives a sort of a broad diagnosis, and aided by immunohistochemistry, that is, they do some markers to do it. And I believe in the future, the sequencing will be an add-on to the histopathology. So tomorrow, what happens is, if I am treating a lung cancer, it is also already happening in the field of lung cancer. What happens is that most of these sequences or sequencing studies are done in the setting of advanced cancers or metastatic diseases, wherein you sort of, give some novel systemic therapies. But what we do in early cancers is you sort of, diagnose it, you image, and if you find it localized, you actually operate that particular patient. But right now, what is happening is, even in early and operable cancers, they are saying you try, for example, I take the prototype of lung cancers because a lot of advances has happened in that. So initially, we used to operate all cases of early lung cancers. Now what is happening is, they are trying to take a biopsy. They are trying to study whether any mutation or any biomarker is being expressed. They are giving that particular biomarker as a targeted therapy initially. Like, for example, this was told about immunotherapy. So there are right now a lot of studies of having immunotherapy. And right now it is being discussed presently. The ASCO, the American Society of Clinical Oncology meeting, is right now happening on an online forum, and a lot of studies of neoadjuvant immunotherapy, that is, prior to your definitive surgery, therapy of surgery, based on what the tumors express, you give certain directed therapies for these particular patients, and then you subsequently see the maximum pathological responses for these patients. In a lot of studies, what has happened is, in early operable cancers, after giving neoadjuvant immunotherapy, about 45% of the patients, when they have operated, they found absolutely no tumor at all. So I think a lot of things are changing. So we have to sort of, as a surgical oncologist, my role is going to get much different. Earlier, we were not actually sequencing these tumors at all, especially for early cancers. But I believe a time has come right now that we would try to sort of, sequence this tumors even at the time of diagnosis itself, so that the therapeutic strategy changes. And the other thing that has happened in lung cancers is, even after surgery, based on the profile of the tumors, you can add certain other therapies. Like, for example, in operable lung cancers, now we have a targeted therapy that you can use after the operation also. So there is a lot of scope, and I strongly believe that sequencing would be clubbed as a part of the diagnostic armamentarium, and would become mandatory for every patient. And I believe every tumor should ideally be sequenced, so that personalized therapy can be offered to that particular patient.
Wonderful. That was our next comment also. Is it a first step towards personalized medicine in India? So yes, probably.
Yeah, absolutely. It is not happening now on a regular basis, but I believe the sequencing platforms are becoming more and more cost effective right now. And bioinformatics is also becoming slightly better. So I feel that in the years to come, with the mushrooming of a lot of companies coming up with these platforms, I believe the costs will come down. Costs of sequencing will sort of come down dramatically. They have come down dramatically, and they will come down even more as well.
So the next question isn't directed to, I think it's directed to the panel as such. Are you considering the idea of CRISPR and developing cancer cell lines in vitro and validate with the drugs and other factors before we opt for chemo or surgery?
Biswa can take it first, and I can possibly add to it.
I think the CRISPR basically is about gene therapy and non-oncology. There is a lot of things going around. One is the spinal muscular atrophy. There is a lot of news going on around the country where CRISPR technology has been used, and very, very expensive. I think it costs around 1.5 to, I think, 18 crores or something. I'm not sure how much it costs, but it's very, very expensive medicine. So the CRISPR technology for our country, hemophilia, thalassemia, are some of those diseases where definitely CRISPR technology will come in, and hopefully some areas will develop. In cancer, currently, I'm not aware of any particular CRISPR technology being used in cancer, but non-cancer, there's a lot of things happening.
Yeah, just to add,
Thank
I think the clinical trials are very recently happening. I think in 2019 only there was a first sort of a clinical trial. And I guess with now the COVID pandemic, with a lot of buzz about this gain of function experiments, I'm not really sure how these technologies will fan out, but I think very interesting. And even in CAR T cell therapies, as Biso was mentioning, I think there is a scope for this technology to come. So looking forward, I think right now it's not there in the clinical care, but it has got very interesting potential, and it is some technology that we can definitely look forward.
So I think both of you answered the next question, which was on CRISPR-Cas available for cancer management, which you've answered. Will it be economical and affordable for common people in India? I mean, this is actually not only for CRISPR-Cas, but also all the sequencing and all the futuristic technologies that we've been talking about. So this is a general comment. Will it be economical and affordable for common people in India?
I will give you one classical example is for CAR T cells. The CAR T cells in US cost around 2.5 to 3 crores. So it's almost impossible for us to get that technology. But IIT Mumbai, they have developed their indigenous CAR T cell, and they are going to price it somewhere around 20 to 25 to 30 lakhs. And except for the virus, lentivirus, which they will probably need to export, rest of the adjuvants and rest of the things is completely Indian based. So I'm definitely sure that if we are going to get all these technologies done in our country, the prices are going to dramatically come down, and our patients will definitely get benefited. And CAR T cells is one definitely in the next 10 years going to change the way we are looking at cancer, at least for hematological malignancy.
And we look forward to people from scientists from Shastra and also the viewers to sort of take a note of this and try to get a cost-effective solution to these pain points that we have raised.
So the interesting part of the CAR T cells is that every T cell can be engineered differently. So you can actually, you can patent anything you want to. It's the technology is not the technology itself. I'm not sure whether it's patent, but the engineering of the T cells where you need to modify, you could do it in numerous different methods. And and with each malignancy is completely different again. So like the CAR T cells from Mumbai, they are only looking at leukemia. But there are diseases like multiple myeloma, lymphomas, and so many other diseases where nobody is looking at. So I think these are areas definitely somebody should venture.
I think the message has gone across to all the incubators, I guess. The next question is, I think, to Dr. Arvind, who mentioned about the eye toilet and so on. So HPV self-testing could be interesting, but when we have vaccines available in India, we don't probably have end users who would be considering this.
Absolutely, that's a very valid point. And two interventions that have actually reduced the cervical cancer burden globally and to some extent in India is HPV testing and vaccination. And I believe with vaccination, and now we have got real-time data also. Initially, the cervical cancer vaccines were shown to be preventive only for pre-cancers, but now we have some definitive sort of publications that have come out, I think from Sweden very recently in the NEGM. There was a publication in the thick of the pandemic that even it is protective in cervical cancers as well. But one note is that even after vaccination, some of these women would have to undergo cervical cancer screening as well, because some of these vaccinations are only meant they are either bivalent or quadrivalent. Of course, the nanovalent HPV vaccination is not available in India as for now. So these vaccines would cover about 80% of the cervical cancers. About 20% of the cervical cancers are caused because of other sort of variants of the HPV. So you still would require some sort of a screening program, which would be preferably a HPV-based screening program, which has shown to be cost-effective. We've actually written about this very recently in one of our journal articles. So anybody is interested so I can share the publication that we have written, because we have the HPV testing with the COBAS platform in our hospital, and we are doing some tests, and we have written about that technology as well. So it will definitely, although the utility of HPV screening testing would be much lesser with the advent of vaccination, I believe it's still relevant, at least in the foreseeable future.
we're running short of time. I'm just going to squeeze in a couple of questions. So these are more general in nature. So software as an artificial intelligence, as a medical device, what do you think would be the prospects in our country where there is an inertial distrust of such technologies? I mean, this is for all the panelists.
Yeah, I can give you one example of artificial intelligence which PMH is using as a software which is called kind of Navia, it's called. And they have kind of used that, it's actually not patient input kind of artificial intelligence, but what they have done is they've taken all these studies. For example, you have breast cancer and you have so much literature available in breast cancer, you have different drugs, different this thing. So they have tried to put all of them into the machine learning algorithm, and algorithm is prepared. So what happens is when you call them, they will take down your history. Your history will be put into the computer, and the computer will be able to select what would be the best treatment option, option 1, option 2, option 3, and it will give you a list. So they are already in practice in TMH. They have last few years they have put it up. So it's not that people are worried that their data will be misused and all those things, but I think there is a lot of gain by using artificial intelligence in for medicine. And one is obviously like this, but more important would be the pathology as well as radiology, imaging. That would be really very, very interesting because you already have dearth of pathologists and radiologists in the country, and you could actually develop a beautiful system where you just put in a CT scan and it just gives you a report. That would be very, very interesting. So definitely a lot of scope of improvement in artificial intelligence.
So the last question again is to the panelists as such, a general comment. Is it viable to continue the separation of research and the practice of medicine? What could be done according to you to improve the situation in our country? So there are two islands, so they want to know how it would get integrated.
No, we need to collaborate. There is absolutely no doubt about that. I think Dr. Ravi Kumar was also suggesting that, and we need to collaborate. In fact, I was just briefly mentioning this a part of my talk. In fact, next door to Cancer Institute is IIT Chennai. So, but we do collaborate. In fact, I do collaborate with a couple of projects with them, but there is enormous scope of doing this. I feel the wall is there between these two institutions. Somehow this wall has to be broken. We need to collaborate more. We need to collaborate more with institutions like Sastra and also all other things. And only then would we be able to make, and I'm sure that as Biswa mentioned, Tata Memorial is collaborating with IIT Mumbai. We are collaborating very, very sketchily with IIT Chennai. And we would look forward for further such collaborations. And I think that's the way to go. That's what I feel.
Thank you, sir. Over to Dr. Ravi now to take.
Yeah, one question, Dr. Uma. In the interest of time, I'm sure we could discuss more, but I just want to reinforce what you all have been mentioning. The revolution in medicine, as we learned now, is not in terms of only their discoveries, how we translate the discoveries in rapid time frame for clinical expression. That's why I use the pandemic as a lesson. And it's not just, it's already been shown, the recovery trial in UK, across all, they put in 40,000 patients immediately to find the answer which would work and which won't. And in oncology, this is the way we have to go, especially. And one, across how we can accordion bleed the clinical trials without cutting corners, that the pandemic has shown that. Second is, as was mentioning by Biswajit and Arvind, we also, I have collaborated with you in Sastra when I was in JIPMER, but it was a nascent collaboration. And right now, even from IIT Madras, we are collaborating with the AIMS, we have an MOU. And from AIMS in Mangalagiri, I've established collaboration with National Institute of Design. Why National Institute of Design? Because they have a stream on communication. So that stream, we need to know how to communicate the message. Cervix cancer is one good example, just Arvind was mentioning. Why is such a preventable cancer? We are still struggling in India because of communication, miscommunication about a vaccine, miscommunication. We did one study in JIPMER, I think Biswajit may know. We tried to do this HPV screening in cervix cancer. So what happened is 2 or 3 families had started harassing their wives and the husbands because they thought she's dirty because having a cancer in the cervix. So this one, when I was there, we had to hush this because we don't want this to be like a big public mismessaging. So these are all the things we need to understand, not necessarily technology and science, but that also how to give less science and more communication to the patients. Cervix cancer is a great example. We should prevent that. And I wrote that about this in Hindu last year. A preventable cancer creating havoc in February last year, in 2020. I wrote. So this is an example. So one last point in terms of other research areas, what's called the abscopal effect, ABSCOPAL, abscopal effect. This is now coming into fore in radiation oncology. And this is where people are now looking at PD-1 immune checkpoint inhibitors and other immunotherapy modalities, how radiating one tumor can have a remission of tumor outside the radiation field. That's one area of ripe for research, the abscopal effect of cancer. They're treating with the combinations. So that I just want to touch, since there is no radiation oncologist today on the panel, a couple of areas in radiation oncology. Broadly, the radiation oncology, we're looking at the different radiopharmaceuticals, how we can hone in. We can looking at beyond 3D to 4D conformal radiation therapy, how we can do real-time imaging, how we can combine immune checkpoint inhibitors and others to how the radiation, not only to enhance radiation, but how radiation can enhance and trigger systems in the body, how we can come on board with the chemotherapy and then mop it up with the surgical therapy. So these are all some of the interactive things that I just want you to entertain. Yesterday's article in Lancet Oncology is a nice study of 60 patients in a New York Presbyterian system, how they have combined the surgery along with the anti-PD-L1 antibody that they use durvalumab, but there are more things you can develop into your bioreactor program of not only the CAR T cells, but the whole panel of immune checkpoint inhibitors and new molecules, and we can then make it into the public domain in a very short time frame and test them one after another in an iterative fashion. So that is I'm sorry for belaboring the point, but I am excited about participating today and wish you Godspeed in creating a revolution in oncology. Thanks again.
Ma'am, your mic is mute.
Thank you, sir. Okay, we keep reminding ourselves to unmute ourselves, I've still not got used to it. Thank you very much, all three of you. There have been really some very interesting leads that needs to be pursued. And I think the take-home message is, yes, that we need to look ahead, we need to collaborate, we need to interact with each other. And there is no ivory tower existence. I think every domain needs to integrate in order to find solutions, as Dr. Ravi Kumar rightly put, right from communication, creating awareness, to using technology and advanced thoughts, trying to look into artificial intelligence, into diagnosis, into training in terms of developing screening products. I think it is all in the anvil. I'm sure Ableist, its mandate is to promote these areas in AI-enabled healthcare interventions. I'm sure that the thoughts that the panel members have put forth are really going to be stimulating all our incubatees and budding entrepreneurs who are listening. And we look forward to a decade of, I don't think I should use the word decade, as Dr. Ravi Kumar put, we need to actually fast track everything. So maybe in a couple of years, we would come out with some exciting products that may probably be beneficial in this field of oncology. Thank you all very much for sparing a wonderful time, for a valuable time. Thank you.
Thank you.